Hello everyone, today we're going to be talking about respiratory drive and worker breathing. And specifically, I want to talk about this because I feel it's a good part of a three lecture series that can explain pediatric areas pretty well. So first of all, I would recommend that you watch this one and then go and watch the basics of respiratory support because I feel they complement each other. And then lastly, watch the cardiopulmonary interactions. And the links will be in the description and at the end of the lecture as well. So today we'll talk about this. You walk in a room, or you're in the emergency department, or you up in the floor, and your intern, or you are the intern or the nurse, and you call you in and they say there's this 6-7 month old or this 12-month old is in distress. They're working hard to breathe and they're desaturating and I need them on oxygen. So today we'll talk about what does it mean for patients to be in distress? What is worker breathing? And finally, are they working to breathe because they need oxygen? And how does working hard to breathe, how is worker breathe, oxygenates them? And if I put them on oxygen, does it really help them or not? And if it does help them, how does it help them per se? Okay, so we'll talk about first, how does breathing work? And the reason why I'm talking this, we're going to first go into some anatomy, some physiology of things, and then it will all make sense at the very end. And also, if you watch all three lectures, it will make even more sense. So first of all, how does breathing work? And it works by interaction of multiple processes. So one, there's central and peripheral chemoreceptors that helps navigate the breathing and stimulate the breathing and guide the breathing. Two, there is mechanical receptors in the lung that responds to flow and volume. There is neural and sensory inputs that get being received from the lung. And of course, the respiratory centers, which coordinates the breathing and the rhythm of the patient. So what happens when you take an inspiration? When you take an inspiration, basically the diaphragm and the external intercostal muscles contracts. And it's an involuntary movement. But it can be taken over voluntarily by the cortex, and you can take a deep breath yourself, but you're not thinking every time you breathe. So what happens when the diaphragm contracts? And it's the only job that the diaphragm has, is to contract. It's the only thing it knows what to do. When it does that, it causes an enlargement in the thoracic cavity. When it causes enlargement in the thoracic cavity, it causes decreasing in the intrathoracic pressure. So that means there's the decrease in the intrapleural pressures and alveolar pressures, which drives the air from the outside to the inside. When expiration occurs, it's a passive action as well, which basically relaxes to the diaphragm relaxes and the lung compliance, and the rest of it depends on the lung compliance and the elastic properties of the lung and the chest wall. So let's think of this. There's something called the sensory input system. There's the central neural respiratory generators and the muscle effector system. All of these go to the respiratory control system and determines your breathing. So all of that happens with the rate and the strength at which the diaphragm contracts, controls the frequency and the volume of the respiration. All of which depends on the firing pattern of the brain stem, which is basically the pacemaker of your breathing. The same exact way there's a pacemaker to your heart. The sensory input system sends signals to the module or sends signals to the respiratory center, which basically modulates the patterns of breathing that you have. And it modulates it based on the metabolic demand that your body have. Okay. So we'll take a bit in this lecture. In this slide, I mean. First of all, there's something called the respiratory drive. The respiratory drive will start with this, the intrinsic respiratory drive. And the intrinsic respiratory drive is basically in your brainstem. To explain this, I need to explain that the drive exactly is present in the brainstem in two areas. One, in your pons, two is in your medulla. And the one in the pons is called pneumothoracic center and apneustic center. In the medulla, there are the dorsal and the ventral respiratory groups. So basically, if you look here, you'll see the pneumothoracic center and the pons right there. And then the apneustic center still in the pons, more posterior towards it. And then when you come to the medulla, you'll see the dorsal and the ventral respiratory center. Over here, you'll see an important center we will talk about afterwards. On the right side, you'll see here is what happens when there's a transection on the breathing patterns. If there is a transection over level 1, everything is fine, right? Except, of course, if the vagus is cut. If you see at the transection of 2, you won't understand what these mean until we kind of explain in details how do they work. So, first of all, you need to understand that the pons and the medulla, work this way. That the dorsal group is mainly, in charge of inspiration. The ventral group is in charge of the expiration, but also in charge of the rhythm generation. Now, it's in charge of the rhythm generation. It's also in charge of, that has a very specialized area called the pre-Potzinger complex. The pre-Potzinger complex has NK1 receptors, and it's going to be important when we talk later on and what kind of drugs and where the drugs affect the respiratory drive. Okay. What about the pontine centers? What is their function? They function in 2 ways. One, it modulates the intensity and the frequency. So the pneumothoracic center basically limits inspiration, but the apneustic center prolongs and encourages inhalation. The second thing we'll talk about is what is the thoracic neuroreceptors. The thoracic neuroreceptors are basically divided in 2. One, there's slow adapting stretch spindles, and there's a rapid adapting irritant receptors. And the slow adapting, both of them, the slow and the rapid, are both mechanoreceptors, and they're found basically in the airways, the trachea, the lungs, and the pulmonary vessels. And their job is basically sensory. And what happens is when they get a stimuli, they convey it through the vagus to the respiratory center. So what happens is the slow will usually give the brain volume information, but the rapid will give irritant information. So if there's a chemical trigger or is a dust or foreign agent, this is the one that will rapidly notify the vagus, and the vagus will notify the respiratory center. What happens is this: there's reflexes that are very notable to the thoracic neuroreceptors, and these reflexes are as which. There's one called the pulmonary stretch receptor, also called a Herring-Brewer reflex, which basically presents that the lung, when it happens overinflated, when the lungs are overinflated, they send an inhibitory impulses to the brain to stop the breath. And basically it tries to protect the lung from volume trauma. And then you have the juxtacapillary receptors, which responds to vascular congestion and interstitial edema. And when that happens, it basically stimulates the brain to increase the work of breathing by increasing the respiratory rate. Now we have 2. We have the peripheral and the central chemoreceptors. The peripheral chemoreceptors are basically the ones that we all studied for at medical school, are the carotid bodies and the aortic bodies. So the carotid bodies are located at the bifurcation of the common carotid arteries, and they basically send their signals to the respiratory center via the glossopharyngeal nerve, so the cranial nerve number 9. What happens in the aortic bodies is they are at the aortic arch and they send it through the vagus, so cranial nerve 10. They still sense carbon dioxide and hydrogen ions, so basically pH changes, but their primarily function is to detect low arterial oxygen levels. What does that mean? It means that yes, acidosis and hypercapnia will increase the sensitivity of these receptors, but only in a partial role. And honestly, these receptors control about like 15% of the driving forces of respiration. So these receptors stimulated by hypoxia more than hypercapnia. Now we go to the central chemoreceptors. And the central chemoreceptors are two: the ventral surface of the medulla and the retrotrapezoid nucleus. And basically, these are primarily sensed pH changes. So this is the ones that we always say that the carbon dioxides are what drives respiration, because primarily sensed pH changes caused by carbon dioxide alterations. So we all know that the carbon dioxide is a lipid-soluble molecule, and which means it can cross the blood-brain barriers. Once it crosses the blood-brain barrier, in the biochemistry, it divides and creates more hydrogen ions. And it creates hydrogen ions in the CSF. It makes it more acidotic and stimulates the brainstem to have hyperventilation, and basically stimulate it to have a deep breathing pattern. So in a healthy individual, the respiratory center is more sensitive to carbon dioxide, which is usually sensed by the central chemoreceptors than by hypoxia. So oxygen only runs the center in severe hypoxemia. So if the patient is severely hypoxic, hypoxemia takes over. And we'll correlate that to later on diseases per se. Last part, which is basically not part of the respiratory drive, that's very essential to discuss, especially when patients sleep overnight. You will get a call and they will tell you the patient is hypoxic, the patient is desaturating. Why is that happening? Is he getting sicker overnight? Why do we usually, or people usually do not prefer to wean overnight, whether that's right or wrong, but you'll see that it's a common practice. And that is because during REM sleep specifically, the breathing becomes very irregular. There's periods of hypopnea, there's a period of apnea, there's changes in the volume, the tidal volume, and the respiratory rate in the lung. Also, there's a paralysis of all of the accessory muscles, and the breathing becomes mainly diaphragmatic dependent. So, respiratory drive is usually out from the brain, is declined, and now the respiratory center becomes less responsive to carbon dioxide and arterial oxygen. So what happens is this: in addition to all of that drive, is that the upper respiratory dilator muscles becomes hypotonic, and the airway narrows, and there's increased airway resistance, which will make sense when we talk about the work of breathing later on. So all of these factors are what we call the respiratory drive. So when we talk about respiratory drive, we talk about hypoxia and hypercapnia. And we notice that the response is different between hypoxia and the hypercapnia. So hypoxia stimulates a breathing pattern that becomes rapid and shallow, and it helps increase respiratory rate more than tidal volume. Why? So why would the brain prefer you being tachypnic more than taking a deeper breath, allowing more flow and tidal volume when you're hypoxic? And it basically aims to decrease the metabolic demand. So it basically aims to decrease the cost of breathing by avoiding the need to overcome the lung higher elastance. The lung elastance at higher volumes means that it needs higher pressures to basically creates that tidal volume. So not higher pressures, higher negative intrathoracic pressure to basically generate higher tidal volume. And to create that, it needs more muscle work, and it means it needs higher oxygen utilization, and it's oxygen that it does not have. When it comes to hypercapnia, it's quite the opposite. What it wants to is take a deep and slow breathing with usually a higher respiratory rate. And the question is why? So when it does that, it limits the deep space ventilation and optimizes carbon dioxide elimination. Okay, so let's give some examples about the things that we were just saying. So first, asthma. One of the most common things you'll see. It comes with hypoxia. And this hypoxia is generated due to obstructive pattern because of the severe inflammation, the bronchoconstrictions, and the mucus production. So hypoxia stimulates the peripheral chemoreceptors. When that happens, the patient will have increased respiratory rate, shallow breathing. Most of the time, asthma patients should be hypocapnic, and that's because basically um, they're hyperventilating, so they get rid more of the carbon dioxide, which is a compensatory mechanism that they're having. If they start to develop paradoxical normocapnia, start thinking that they're going into muscle fatigue and that their respiratory failure is pending. So they should be blowing off carbon dioxide because they're working harder and harder to breathe. But when they walk in, and if you do any and the carbon dioxide is normal, it's actually because they're fatigued. Second thing, I'll talk about obstructive sleep apnea, which is the part of obesity hypoventilation syndrome. It accounts about, I don't know, obesity hyperventilation syndrome accounts about maybe 80 to like 90% of causes of obstructive sleep apnea. There's other causes related to sleep. In obstructive sleep apnea, in the setting of obesity, the lung and chest wave compliance and the mechanics completely change. So basically there's hypoventilation, there is hypercapnia, which means there's increased respiratory drive and work of breathing. The problem is they fatigue early because of the load on the chest wall. So they become both hypoxic and hypercapnic. The biggest problem is that they are chronically hypercapnic, which leads that respiratory acidosis is compensated with metabolic alkalosis. The trick here is that the bicarb will decrease the sensitivity of the central chemoreceptors to change to PCO2. So now they are taken over by hypoxic drive, and that's why they usually have persistent hypercapnia and have hypoxic drive. And once you over oxygenate them, you take away their drive, and that's when they arrest. And it's very important in adults if you're talking about COPD, but here in pediatrics is obstructive sleep apnea overnight. When you put them on BiPAP and increase oxygen, or when you put them on high oxygen, actually makes them worse. They become sleepy. And then neuromuscle disease. Neuromuscle disease is common in pediatrics, and it's basically the respiratory center is fine. There is no problem with the respiratory center, is it? But the problem is the muscle weakness. The muscle weakness will cause hypoventilation and hypoxia and hypercapnia, basically. What about drugs and toxins? And we promised this when we said we gotta talk about the pre-Putzinger complex. And I want to say this: pre-Putzinger complex has the NK1 receptors, but also has the mu opioid receptors. So opioids drug, when they're overdosed, that's the center that is affected by it. What about inhaled anesthetics? Inhaled anesthetics functions by decreasing the response to increase carbon dioxide and basically decrease oxygenation. So basically blunts the respiratory drive. About benzos. Benzos acts as a GABA receptor. And when it acts on the GABA receptors, it decreases all of the neuronal functions. So the respiratory pacemaker system is basically inhibited. When it comes to alcohol, which is a more common pathology talking about adolescents and adults, but it blunts all of the body response to the increased carbon dioxide levels. So patients will be having basically hypercapnia, but the body will be stunned, does not know what to do with this information. This is not related much, but I like it because I like mythology, and it's called Undine's Curse. Undine was a quick segue, was a water nymph in the Greek mythology. And basically she fell in love with a human, and she turned human to be with him. The whole purpose that she turned human is because he promised her that in every waking breath, he's going to always love her. He's going to love her until his every waking breath. So at one day, she kind of caught him committing adultery, basically. And she cursed him that as long as he was awake, he could breathe. But if he ever falls asleep, he would stop breathing and die. And in the pediatric world, this is called congenital central hypoventilation syndrome, which basically is a genetic disease caused by a mutation that the respiratory center is unresponsive to changes. So basically, now you can no longer breathe unconsciously, and it really depends on your conscious cortical control of the patient. Now, here we'll talk briefly before we go into lung compliance and functional residual capacity about something specific. So if we look here, we need to understand what is functional residual capacity. And to explain this, I have to explain this whole graph. One, this is what a tidal volume is, which is the volume that you take in a spontaneous breath. There's inspired reserve volume, which is if you really worked hard consciously to take a deep breath, that's the inspired reserve volume. It's the reserved volume for you to take more forced inspiration. And both of them are called the inspiratory capacity of the lungs. Now, if you have a reserve volume in inspiration, you should have a reserve volume in expiration. And this lies when you do forceful expiration. And you can force more. Now, if you expire everything in your lungs will collapse. So, whether you like it or not, there's usual residual capacity or residual volume. A residual volume is what is left inside of the lungs to prevent it to have atelectasis or collapse. And both of them together are called a functional residual capacity. So, what's a vital capacity is both what you can do at maximum inspiration and at maximum expiration, and leaves you with the residual volume. And then total lung capacity is basically measuring every single thing that is in your lung. So looking at inhalation and expiration here, what happens is this. When you take an inhale, and when you inhale, the intrapulmonary pressure will decrease. The intrapleural pressure is also decreased, and your tidal volume is slowly going up. When you exhale, the intrapulmonary pressure increases, the intrapleural pressure increases, and your tidal volume starts to decrease as you exhale. So now that I hinted for it, this is the functional residual capacity. A functional residual capacity per se is the amount of air left in the lungs after the tidal expiration that we mentioned. So it's important because in the pathophysiological implications that can occur with it, functional residual capacity can be affected. We need to understand one thing. The functional residual capacity is really influencing what is inside of the alveoli per se. So during inspiration and expiration, during the alveolar oxygen levels, so alveolar oxygen level will increase and alveolar PCO2 will decrease during inspiration, right? Because the air goes in, will pump up more oxygen and will take out more carbon dioxide. Contrary happens during exhalation, where the PA capital O2, so oxygen inside of the alveolar, will decrease and the carbon dioxide will increase. Basically, as the pulmonary capillary blood continues to remove oxygen from and add CO2 into the alveoli, which you can see here, right? So the PCO2 and the PO2 during inspiration, you'll see with inspiration, oxygen is going up, carbon dioxide is going down concentration-wise. With expiration, oxygen is going down, carbon dioxide is going up to be exhaled. So FRC acts as a buffer, which minimizes the changes between both them. FRC represents the environment available at the pulmonary capillary blood for gas exchange at all times. So after you take a full breath, FRC is always there to help that gas exchange regardless. Now, we'll talk about these two graphs. On the right side, this is the oxygen dissociation curve, right? So we want to discuss that one of the major consequences of decreasing the functional residual capacity is basically hypoxia. So a decrease in the functional residual capacity will result in a sharp decline in the oxygen inside of the alveoli during exhalation. And this is because there's a limited volume available anyway for gas exchange because your FRC is low. So now the pulmonary capillary blood will have lower oxygen during exhalation, which uses a decline in the oxygen inside of the arterial blood. Which means that any increase in the alveolar oxygen will increase the oxygen into the arterial oxygen levels, right? During inspiration. So whatever you do during your inspiration to compensate for that decreased arterial pressure during expiration. So you don't get confused. What happens is your FRC is low, you'll have lesser oxygen during expiration. You'll have lesser oxygen in your arteries. When you inspire, you try to compensate for that, basically. So what happens is this. Because most of the oxygen is combined to hemoglobin in your bloodstream, regardless of any amount of inspiration you take, if you have decreased FRC, you cannot compensate for that decreased oxygen level in the alveolar or the arteriole. At this point, if you have decreased FRC, most of the time you will need positive end expiratory pressure, an increase in your inspiratory time to compensate for it. That will make more sense when we talk about worker breathing, and more sense when we talk about parts in their management of hypoxia. So lung compliance, which is the one on the left side. If you listen to the lecture on the basics of respiratory support, you'll see that we talked about the pressure loop, the volume pressure loop, which we'll talk about briefly in the next slide. But I also mentioned this one, the volume and the distending pressure. So lung compliance is significantly influenced by the function residual capacity. So B here is the normal. C means there is high FRC. A means there is low FRC. And this means something. That FRC is abnormally higher in the interthoracic airway obstruction, which basically means incomplete exhalation, and abnormally decrease the alveolar interstitial release, and also decrease in the alveolar. So it will increase in your obstruction disease and will decrease in your alveolar interstitial diseases. So an excessively high or low FRC, the tidal volume is either requiring high inflation pressures or to increase your worker breathing to like any spontaneous breathing. So basically, to explain this again, your FRC here is high because of an obstruction pattern. Your FRC here is low because of a interstitial lung disease pattern, and both of them will affect the volumes, and both of them means you'll need higher pressures to attenuate your FRC. You'll need low pressures, but you will attenuate only low volume because you don't have any reserve when compared to the lower. So when you have spontaneous breathing, your patient will have increased worker breathing to try to compensate for that. Okay. So when they have increase of worker breathing, let's go back to what we said in the basic respiratory support lecture, but in a different way. So what is the function of the lung? It oxygenates and it ventilates. When it ventilates, the one equation I want you to remember is minute ventilation, and minute ventilation is basically tidal volume multiplied by respiratory rate. So these are two major factors influencing your ventilation. Why is this? This is the volume pressure loop. So here's your tidal volume, here's your peak pressure, here's your peak inspiratory pressure, and this is your tidal volume, which tells you something, that tidal volumes, which influence the ventilation, is also influenced by the pressures. So if you manipulate pressures, you can manipulate your tidal volume. Oxygenation. So we'll talk about one of the most important equations, mainly in fellows, but you also need to know as residents and medical students when you're studying the physiology. It is the alveolar oxygen equation, which tells you the partial alveolar oxygen depends on these things. And let's simplify it. One, it depends on your FiO2. How much oxygen are you giving that patient? And usually it's about 21%, 0.21, which is the room air. And then it depends on two kinds of pressures. Atmospheric pressure, which is dry pressure, which is the pressure coming from the outside to the inside, which is this at sea level. And tell you vapor pressure, which is wet pressure, which is the pressure inside of the lung. So basically, it's how much oxygen are you getting, percentage-wise, multiplied by the difference between the pressures on the outside and the inside. And you subtract that from your CO2, and the respiratory equation is fixed. So CO2 plays a factor in the oxygenation that you get, which will make sense when we talk about worker breathing. Another point of view to say is the mean airway pressure depends on your inspiratory time, expiratory time, and they are multiplied by your peak inspiratory pressures and your positive end expiratory pressure over total time of breath. We can deduce two things. One, oxygenation depends on pressures more, which means effort. Ventilation depends on diffusion more, which makes it less effort to the lungs. But it influences the oxygenation still, and your pressures influence your ventilation as well. So lung compliance. So you'll see this is the lateral diameter. So this is a fetus, a newborn, a 3-year-old, it's basically a newborn, a 3-month-old, a 3.5-year-old, an adult. Which tells you what is compliance. Compliance is the change of volume over the change of pressure. So let's explain all of that. One, you need to understand that children, specifically infants and neonates, are at specific mechanical disadvantage when we talk in comparison to adults, pertaining compliance, of course, especially when we talk about chest wall compliance, not lung compliance. One, the infant's ribs are more oriented horizontally rather than what the oblique movement of the adults. So more horizontal. The diaphragm is more flat than concave in pediatrics. See, flat and horizontal in pediatrics compared to adults. Which means when the diaphragm contracts, it flattens and becomes even more or less dominant. The infant is therefore unable to really duplicate what a normal breath is, which is usually upwards and outwards movement of the obliquely oriented ribs. And the diaphragm is downward displaced of the dome of the diaphragm. So, because they lack that obliquity and they lack the dome, it means one, the diaphragm is mechanically disadvantaged. Two, the infant's rib cage is soft. And it's usually soft because we want it not to break or to hinder their passage during birth. However, this places them in a vulnerable situation. When the chest wall compliance is one of the major determinants of functional residual capacity, if the chest wall and the recoil and the lung recoil are usually opposite to each other. So you'll see here that usually the chest wall and the lungs wants to pull inwards, the chest wall wants to pull outwards, right? So what happens in this? There's a balance to maintain. So what happens is in the functional residual capacity is reached where the point where the outwards elastic recoil of the thoracic cage counterbalances the inward lung recoil. And this balance is basically attained when there's lowered lung volumes in those young infants. So they have extremely high thoracic compliance compared to the older ones, and the lungs there's more resistance. So this means they have this imbalance per se between their compliance and their FRC. So when you measure FRC in infants, it's usually higher than expected, and that's because the respiratory muscles of infants maintain the thoracic cage in an inspiratory position at all time. Additionally, they usually trap more air. Okay. So when you look at the figure on the right side over here, we'll see that the elastic coil is relatively more compliant, and chest wall is balanced by the lung recoil at the lower volumes in infants than adults. So we'll see here lower volume of the lung with higher chest compliance at a lower pressure to maintain functional residual capacity. So let's talk about this. One, summary wise, there's an increased chest wall compliance, which is a disadvantage the kids has. Two, there's decreased muscle tone. Remember when you talk about REM sleep, it's decreased more in pediatrics, and decreased muscle tone, especially that occurs during REM sleep or with CNS depressions, allows for a greater chest wall retraction because of less opposition from their lung recoil itself. which means that FRC is less. So 1, when they wake up the kids at night, their FRC is less, and that's why they're usually desaturating more. 3, the respiratory muscles of infants are poorly equipped to sustain larger workloads, and we need to understand this from this aspect of things. They are easily fatigued than older kids, which limits their ability to maintain adequate ventilation, especially if they have a lung disease. Imagine if they already have a chronic lung disease or underlying condition, and they even got sicker or get an acute exacerbation. So, in diseases of poor lung compliance, such as atelectasis or pulmonary edema, there's excessive lung recoil, resulting in a greater retractions of the soft chest wall, right? Which means more loss of your FRC. Because adults, when you compare it to adults and children, they have stiffer chest wall. 2, increased negative thoracic pressure requires to overcome airway resistance. That happens in obstructive lung disease. Also produces great chest wall recoil, which also decreases FRC. Okay, so at this point, when they tell you give them pressures, like PEEP pressures, is usually beneficial because it stabilizes the chest wall, also increases their FRC. 4, young infants do not tolerate sustained respiratory loads, as well as older children and adults. What does that mean? So it means that 2 things. There's a respiratory muscle ontogeny, which is basically characterized by 2 things. They have 2 muscle fibers. And 2 muscle fibers are type 1 and type 2. And type 1 are slow twitching, high oxidative in nature, while type 2 is a fast twitching and low oxidative in nature. This means that type 1 usually have a low contractions, but fatigues hard, right? It slowly contracts, but can be resistant to fatigue. Type 2 means it contracts fast, but it's very prone to fatigue, right? So the portion of type 1 in the diaphragm and intercostal muscles of premature infants is about 10%. Becomes about 25% when they're full term, and like 50% when they come to 2 years of age, or more than 2 years of age, which tells you that the type 1, which is a more resistant to fatigue and low contracting, is lacked in young infants. So they have the faster acting and the faster fatigue muscles in. So that takes away from their compliance. Last thing we'll talk about compliance here is going to be, about this part before we go back to our case, is airway resistance. And airway resistance at this point needs to be defined as the resistance is inversely proportionate to the radius to the power 4. And this means length and this means viscosity. You can also see this equation in the circulation length. So the practical implication of this is that the pressure flow relationship is that the airway resistance is inversely proportional to its radius to the power 4th, and that's the most important part of it. This means that if the airway lumen is decreased by half, the resistance is increased about 16 folds. So let's go back to our patient. Patient is in distress. They're working hard to breathe. What can we do for them? And that's the question. What's work of breath? Patient is tachypnic. He's retracting. He's having accessory muscles, and we need to understand the difference between them. He's grunting. He's nasoflaring. He's using a respiratory. He's using a tripod. Position. Or at the end, they can become cyanotic. Or they can have altered mental status. So why is the lung working with these mechanisms when the patient is hypoxic? So let's talk about tachypnea. Tachypnea is a respiratory rate increase, and we said based on the minute ventilation that tachypnea helps with ventilation, not with oxygenation. So that means the patient is trying to ventilate. When it tries to ventilate, it's trying to decrease the respiratory acidosis, by which it tries to avoid cellular damage and myocardial depression. And tachypnea is one of the most important signs of low respiratory disease. Then why is the difference between retraction and accessory muscles? And are they used for more in oxygenation or ventilation? So we talk about retractions. I'm talking about intercostal muscles, subcostal muscles, supraspinous muscle. And it depends on the diaphragmatic contractions and only the diaphragmatic contractions. And that's a passive action. It's involuntary, done by the patient. The diaphragm only knows to contract and passively relax, which means this is going to increase the negative intrathoracic pressure, which will increase flow, which will increase tidal volume. And again, for minute ventilation, tidal volume and respiratory rate equal ventilation. So now the patient is improving by retractions during minute ventilation. Even though they're hypoxic, they're still trying to ventilate, not oxygenate. What about the accessory muscles? Accessory muscles are more conscious, voluntary usage of things per se. But it's involuntary, increased worker breathing in pediatric populations. Here I'm talking about scalene muscles, sternocleidomastoid muscles, trapezius muscles, pectoralis major. These are active use of muscles which basically helps to ventilate the same way by increasing the flow and increasing your tidal volume. When you start seeing accessory muscle usage, try to think your forced expiratory volume in 1 second is about decrease. And I think what I've read in adults is about when you see that sign, that means your FEV1 is decreased by about 30% already. Okay, what about nasal flaring? Always the patients are nasally flaring. Let's remember, resistant is equal 1 over inverse proportion to the radius to the power 4. So if the patient is nasally flaring, they're trying to increase their upper airway radius, which means they will lower their resistance, which means they will increase their flow, increase their tidal volume, they will ventilate. So if they're doing all of this and it's not working, patient starts to grunt. And a grunt, if you see it, you will know it. And a grunt is basically a forced expiration against the partially closed epiglottis. And why are they doing this? They're doing this to create something called the back pressure. To basically, they're trying to give PEEP. They're trying to increase their own positive end expiratory pressure. So one, it helps with oxygenation and it also helps with ventilation. And it helps by increasing your FRC. So by increasing the surface area and decreasing atelectasis, by increasing your PEEP and grunting, you increase your FRC. We have to know one thing is, in infants or neonates, there's something called the closing capacity overall in the lung, which is basically the FRC below which atelectasis can occur. Closing capacity and FRC in neonates are almost equally the same. So by grunting, they're trying to regain their FRC to prevent atelectasis from occurring in atelectal trauma. Last thing is tripoding position, and basically it's really, really sick kids, and you can see an upper airway disease as well, and it's using the gravity to decrease the resistance and increase chest wall compliance. And ultramantastats will occur from basically stacking of CO2, and cyanosis is from like severe hypoxemia. Okay, I hope that made sense. And again, I would recommend after listening to this, go to the basics of respiratory support, which will make you understand from the NICU and PICU standpoint the escalation of the respiratory support and why are we using these escalations, not others, in a certain way and how to explain it. And then last but not least, to understand what cardiopulmonary interaction is. And it's, I think, once you listen to all three of those, it will make lots of sense to understand the pediatric ARDS lecture, which will be next. Thank you.